I want to join the chorus of speakers to thank the organizers for inviting us to this wonderful event. This is my first trip to Israel, and it's already been very memorable. Laurie has often cast me as being the naysayer, and I don't know why that's true, but I think it's probably because I tend not to get too carried away. So I think that HIFU will remain a niche treatment in prostate cancer. There is, of course, a risk of being anti-technology. And so in the early 1800s, flyers such as these were put up around the middle of England, encouraging people not to break these so-called frames. And really what was happening was that looms had come out, and people believed in this mythical King Lud, and these are known as the Luddites, who saw their industry, as they were doing this by hand, be taken over by a machine. And so I certainly don't want to seem like a Luddite up here, but I think that HIFU on its own merits is easy to attack. So what do we know about HIFU? Well, the truth is we actually don't know very much at all. There have been no randomized controlled trials of this technology. There have been only 31 uncontrolled trials as primary treatment of HIFU, and there have been 2 uncontrolled studies of HIFU as salvage. And if you want to find all this listed, this publication just came out earlier this spring, which basically summarized the entire world's history of HIFU in one article. It sort of speaks to how little we actually know about this. The second thing is that the disease-free survival after HIFU is really quite awful. So this is 356 patients who were treated with the ablatherm device from 1994 to 2009 and gathered together in a registry, and all underwent primary whole gland HIFU. And guys and ladies, that curve is really bad for prostate cancer outcome. I mean, you're almost at 50% failure rate at 7 years. There's not a therapy that any of us apply that looks anywhere this bad. And one of the things that's really concerning is that if you actually risk stratify these patients, it doesn't seem to make much difference at 7 years. They all have done really badly. So unless HIFU were to change significantly from how it's been applied, I don't think that these results are going to be acceptable in the future. Well, why doesn't it work? Our colleagues in Canada, where HIFU is approved, and you may know that the FDA has not allowed HIFU to be approved, and so insurers in the United States do not pay for this. So anybody in the United States who wants HIFU has to either go to Canada, go to Europe, or go to the Caribbean to have that treatment done. But our Canadian colleagues have, unfortunately, had an opportunity to see how HIFU fails, and I would draw your attention to this paper that came from the Toronto group. And the reason it doesn't work is that it actually doesn't eradicate the cancer. So these arrows are pointing at small pattern 4 cancers in the midst of this HIFU-induced scar, and this was a tumor that was removed at radical prostatectomy. It should be mentioned that not only are the operations a little more difficult to perform after you've burned the prostate gland, not surprisingly, but that cancer is found to be T3 much more often in these lesions. So what does HIFU have to do to be widely accepted? And these are, I think, hurdles that are large. The first is they need to establish and validate criteria for success. It's really wholly inappropriate to use a radiation-based definition, which is designed and was prospectively validated for radiation failure as a prognostic of progression, and apply that to a therapy that is completely different than radiation. They have to demonstrate that there's actually a clinical benefit, and this is, as you know, a regulatory requirement, and it's actually a quite high hurdle, at least in the United States, for them to overcome. And they need to design and complete acceptable randomized controlled trials, and the trial designs here are not trivial. So what are the endpoints that we're going to have the patients to wait for? Metastatic disease, overall survival, those answers are going to come 15 and 20 years from now. And how are you going to compare this? Are you going to compare it against whole gland therapies? And as you know, our field has actually done a pretty bad job at conducting such trials. And I think we also need to have much better understanding of what we're going to tell patients when we apply HIFU about the real possibility that, in fact, they will have a progressive event that requires intervention in the future, and what's the likelihood that that second intervention will be successful. One of the reasons that I would state the very obvious thing that a negative biopsy is not equivalent to no cancer is that many of the trial designs that have been proposed base it on a negative biopsy. And so again, using the Canadian Toronto colleagues, here's a beautiful paper where they looked at core biopsies of patients who had progressed. And if you look here at panel A, you can see that the majority of that core looks like fibrosis, which is what you expect HIFU to induce. But at one end of that core, here you have a nice little pattern 3-3 cancer that frankly hasn't been altered at all in its architecture. So I think that if we rely on negative biopsy, we always have the concern, did we actually sample adequately? And really the only informative biopsy is the one that shows us that cancer is still present. Just a sidebar about targeted HIFU. I think this is really quite a misnomer, as I think most targeted therapy is. First of all, only about a quarter of cancers are truly unilateral, and these really cannot be identified by any currently clinical or pathological feature. The dominant lesion cannot be reliably detected, and I think we should have open questions about whether, in fact, the largest lesion is the one that actually is the most lethal, and the biological significance of this is uncertain. And despite the advances that are being made in MRI technology, we all have to be honest with ourselves so that there is no current imaging or biopsy technique that can identify every cancer in every single gland. And so really, when you think about focal ablation, which is remarkably not focal when you do hemiablations, is still pretty much a shot in the dark. The other problem with HIFU, and I think with many of these, quote, minimally invasive technologies, is that when you have an endpoint that's not clearly defined in a slow progressive disease, you can apply these therapies and not have any idea how badly your outcomes will eventually be, and this can lead to widespread technical incompetence. And those who are the biggest advocates for focal therapy or for this sort of an approach have said in an editorial, it is likely that HIFU treatments practiced in low numbers by individual surgeons and centers may contribute to producing unfavorable results. Now, as you know, we can't have every single patient going to experts like my colleague here from France who spoke earlier. We have to be able to have a technology that can be used in the population at large, and we still don't have that. The response, of course, from the authors is that defining competency and procedural volume to maintain competencies is problematic when the efficacy of HIFU is far from clarified. And then I just bring your attention to projections that we would see in the United States. These are data that look at the death rate from prostate cancer, and if you simply look at the blue bars, you can see that one of the truths about prostate cancer, at least in the United States, is it is an age-related phenomenon. And so the largest group of men who die of prostate cancer are elderly. And this will only increase in the year 2025. And in the year 2045, which if I'm fortunate, I'll be 85 years old and hopefully still be alive, you can see that death rate from prostate cancer is actually going to be significantly high in elderly men. So any therapy that we apply today, we need to think about who we're treating and why we're treating, because really men who die of prostate cancer are old. 80 is the median age of death in the United States.
1 minute.
So HIFU will remain a niche treatment. As currently applied, it has never undergone controlled testing. It has inferior oncologic results. It does not reliably eradicate prostate cancer. It faces considerable challenges for FDA approval. Has even bigger challenges when applied focally. Risks inadequate application. And the reason to effectively treat prostate cancer is to avoid these events 10 and 30 years later. So thank you for your attention.